Prolonged exposure therapy. What causes dysfunction? Post-traumatic stress disorder is a common disorder, especially among those that have experienced or witnessed trauma. Roughly 6% of those that are exposed to trauma will develop PTSD. Not all trauma is equal. The severity of PTSD has been found to be highest among sexual assault victims. Next, those exposed to military combat have the next highest level of PTSD intensity. The PTSD symptoms for natural disasters and robberies tend to be a little less severe. PTSD is not solely caused by the traumatic event. It is caused by multiple factors, which include events following the trauma. The role of assessment. A diagnosis of PTSD is not sufficient to determine if prolonged exposure therapy is the best treatment. Clients need to be emotionally prepared to revisit their past trauma. If they have a high risk for suicide, they are not a good candidate for prolonged exposure therapy. If they're experiencing symptoms of psychosis, they're not a good candidate for prolonged exposure therapy. If they're at risk of being assaulted, like if they're living in a situation with domestic violence, they're not a good candidate for this therapy. Now, if they have substance use disorders, they can get treatment for their substance use disorder at the same time that they receive prolonged exposure therapy, and that has been shown to work. Now, the nature of therapy. Prolonged exposure therapy is an evidence-based treatment that helps people survive trauma, to process the emotions associated with it, and to diminish the symptoms of PTSD. Prolonged exposure therapy is a type of cognitive behavioral therapy. Prolonged exposure therapy grew out of emotional processing theory as a means to deal with traumatic memories. So the goals of this therapy, we want a reduction of negative cognitions. We want to see diminished fear activation. That's what we call habituation. Habituation includes the reduction of distress and anxiety. So the central constructs for prolonged exposure therapy are 4 different items here. We're looking at breathing retraining, at trauma education. We're looking at imaginal exposure and in vivo exposure. Breathing retraining. Improved breathing has shown to reduce anxiety by slowing the speed of exhaling. Stressful events cause shallow breathing, which results in less oxygen to the brain. Breathing exercises teach a deep breathing in through the nose and slowly expelling that air to the point where you're squeezing the abdominal muscles to get all the air out before doing another deep inhale. Deep breathing is typically taught in the first session, and then the homework assignment will be to do 10 minutes of deep breathing on a daily basis. Now, trauma education. We teach clients about trauma and its effects. We emphasize that while the reactions are normal, they are not beneficial. Dangerous events naturally cause anxiety and fear. They can shake our sense of safety and security. Negative feelings that we feel in present time, can bring back memories of past trauma. Triggers can be things like places and activities, smells and sounds, Triggers can cause physiological symptoms like speeding of pulse, shallow breathing, shaking, or nausea. Imaginal exposure is something that we try to start in the second session, and we introduce the concept of subject units of discomfort, the SUD scale, which is 1 to 100. 1, it doesn't cause any discomfort, and 100 is to the point where they cannot experience, or they can't deal with it. It just disturbs them too much. So typically, a person with PTSD is going to avoid things that cause them discomfort. And they think avoidance is the solution to dealing with PTSD, but the avoidance actually keeps them trapped in the PTSD, and does not allow them to recover from it. So we want to use imaginal exposure to start exposing them to some of those avoided objects. They can close their eyes and just imagine it, or if we have virtual reality technology, we can use that, and that can help with these imaginal exposure. In vivo exposure are activities that induce the discomfort. It's a trigger, a place that they actually go to, or maybe a sound that they hear, a song, or a smell that they hear that causes them to have that discomfort. Now, these activities can be things like driving, or sitting in a crowded theater, or walking outside after dark. Part of in vivo exposure is also going to be trying to get them to do some things that they used to like to do, but they now are not interested in it. Things like going to a baseball game, or playing golf, or going to the library and reading a book. These might be things that they used to enjoy, but now they have lost interest. And so in vivo experience, we're going two different directions with it. One direction is we're going to triggers that cause them discomfort, and the other direction is that we're going to activities that they used to avoid or used to enjoy, but are now finding little pleasure in. The in vivo exposure for the activities that cause discomfort, we're going to look for those activities that cause that discomfort level in the SUD score between 40 and 50. Now, the techniques. The client is going to learn to practice deep breathing in the first session. That's one of the first things we are going to get in with them, and we're going to give them some homework and ask them to continue doing that at home on a daily basis. In the second session, the client can start creating a list of triggering activities and putting an SUD scale. Are these cause them 30 score of 30 discomfort, or is this causing a discomfort of 60 or 80? List the activity and what is the discomfort level of that activity. Then the client is going to begin imaginal exposure, hopefully in the third session. If virtual reality technology is available, we can use that. The in vivo exposure to events with the SUD rating of less than 50 are going to be assigned as homework after the third session. That's ideal. That's how we'd like this to progress. The therapy process. Well, education during each session. Clients are going to learn about reactions to trauma initially and as therapy progresses. They learn more about the specific symptoms and how those symptoms are fed and how they can be diminished. We're talking about teaching them both about the effects of trauma and about the disorder, PTSD. We're teaching them both about those things throughout the sessions that we're having. Then we're getting into the deep breathing technique in the first session. The clients are going to practice this in between sessions, and hopefully they discover that this deep breathing helps reduce their anxiety, so then when they start to feel their anxiety level rising, they know this is a tool that they can use in order to start reducing that anxiety. When clients want to avoid or flee triggers that cause distress, this is something very natural. However, we want them to learn that in vivo exposure can help reduce that distress. That while they want to avoid it, if they don't avoid it and if they face it, the longer they are with that trigger, the more the anxiety will diminish. So we want to encourage this in vivo exposure. Let's take a look at a case example here of Elijah and Alicia. This is a couple that have been, well, they're romantically involved. They have a child together. They live with Alicia's parents. They've been together for 8 years. Both of them are diagnosed with PTSD. Elijah is a combat veteran. Alicia was sexually abused as a teenager. There is a history of angry outbursts, so there's some emotional dysregulation that's happening there. There is no history of physical or sexual abuse in this relationship. Elijah, starting the therapy, he got a 36 score on the clinical administered PTSD-5 scale. The first few sessions were spent primarily developing the therapeutic alliance. He did not get into the imaginal exposure like we had hoped. In the sessions 4 to 7, we were introducing this imaginal exposure, some difficulty in those sessions. Session 8, we had some success with the imaginal exposure in this case sample. In session 9 and 10, success in vivo exposure. Elijah actually had a very in-depth conversation with a trusted friend about the activating event. His first sergeant had died. He witnessed this. He saw the bloody body, the damage that happened to the face. It was a very traumatic event for Elijah, and he got into the nitty-gritty details with one of his friends. In case example with Alicia, well, she scored 31 on this clinical administered PTSD-5 scale starting out. Sessions 1 through 3, they developed the therapeutic alliance and they got into imaginal exposure. So in her therapy, she was progressing pretty much along that line that we hope to see clients progress on when we use this therapy with them. Sessions 4 through 7 got into the imaginal exposure and added in vivo experience. Now, she was sexually assaulted multiple times as a teenager, 2 different individuals, once when she was, not once, but several times when she was 13, and then also several times when she was 15 with the 2 different individuals. In her in vivo experience, she actually went back to that neighborhood where it happened and went back to the house where it had happened to confront that trauma. In sessions 8 and 10, they continued to do imaginal exposure and had success doing that. Now, in these examples, Elijah went from the beginning score, the CAP-5 score of 36, went down to, at the end of the therapy, a CAP-5 score of 18. We saw Alicia started out with that CAP-5 score of 31. She went down to a CAP-5 score of 7. So at the 1-month follow-up, we saw Elijah's CAP-5 score go down even further to an 8, and Alicia's CAP-5 score at the 1-month follow-up went down even further to a 3. Now, both described their lives at the 1-month follow-up as thriving. Elijah said the difference was like night and day. A critique of this theory. Now, the process of this therapy is very disturbing, disturbingly distressful before they get relief. So it gets worse before it gets better. It's not for everyone that has PTSD. As we mentioned, if they have suicidal tendencies, if they're in a domestic abuse situation, or if they're experiencing psychosis, then this therapy is not something that is going to work with them. That has a very high dropout rate. The Veterans Administration has a study out there showed as many as 68% drop out of this. So there is a much higher dropout rate than what we want to see. It's very effective for those that get through it, but a lot of the clients do not make it. They don't get through it. Here's some key resources you may want to put a pause on here if you want to write down what these are or take a screenshot. The VA has a National Center for PTSD. The website there has some information on this type of therapy. Also, the Anxiety and Depression Association of America has a website, and they have information there as well. References for some of the articles where the information came from for this presentation. Also, credit for some of the graphics that were used is listed here. You can take a screenshot, put it on pause if you're interested in looking up any of these citations.